Okay, I think we're going to get started. So welcome everyone to our May installment of the KT Canada seminar series. This will be our second one being fully remote. I hope everyone is doing well out there. So we're happy to have with us today Dr. Jennifer Tomasone. So she's going to be presenting her work on using KT science to disseminate and implement national movement behavior guidelines. So I'm just going to briefly explain how the question period works. So once Dr. Tomasone has finished her main part of her presentation, after about 40-45 minutes, if anyone has a question, please type it in via the chat box. If you can type it to everyone, that would be ideal, so everyone can see your question, and then I'll read it out to Dr. Tomasone. You can also send it just to me, which is KT moderator, so either to everyone or KT moderator would work. I have muted everyone on entry, so hopefully we won't have background noise. Sometimes something happens and there is some, so if that does happen, just bear with me for a second while I take care of that. Okay, so a little bit of background on Dr. Tomasone. She is an assistant professor in the School of Kinesiology and Health Studies at Queen's University. Her research program focuses on closing research to practice gaps for physical activity behavior change. She was part of the leadership team for Cancer Care Ontario's exercise guidelines for persons with cancer and has experience disseminating and implementing physical activity guidelines from community-based to clinical settings. She is currently the knowledge translation lead for the upcoming Canadian 24-hour movement guidelines for adults aged 18 to 64 years and 65 and over years, funded by the Public Health Agency of Canada and the Canadian Society for Exercise Physiology. So Dr. Tomasone, thank you, and I would like to pass it over to you.
Great, thanks so much for the introduction, Megan, and good afternoon, everyone. I appreciate you joining us today. I want to particularly thank KT Canada for the invitation to present today. I have been attending these seminars every month since I was a PhD student, so I'm honored and a little nervous to have the opportunity to be on the presenting side today. But I really am excited to share some of the work that my team and I have been doing to prepare for the launch of the guidelines that Megan just mentioned. So I once again would like to acknowledge the Canadian Society for Exercise Physiology, who have commissioned and owned the guidelines, as well as the Public Health Agency of Canada for funding the guideline development and KT processes. So just before we dive into the official objectives for today, I want to give you some background about who I am and how I got to my role as the knowledge translation lead for these guidelines, what these guidelines are all about, and then the knowledge to practice gap with respect to the 24-hour movement guideline enterprise in Canada to date. I'll then outline how I drew on KT science to try to close this knowledge to practice gap. So our objectives for today are that I'm hoping you'll be able to describe the integrated KT approach for disseminating and implementing these guidelines, to describe how the knowledge to action framework can be operationalized for national behavior guideline KT efforts, and then to discuss some challenges and applications of the process by other guideline KT groups. So I'll start by taking you back about 10 years. When I completed my PhD in physical activity behavior change, I was engaged as a trainee with KT Canada. I wanted to bring KT science to my dissertation, wherein I developed, implemented, and evaluated a number of nationwide physical activity interventions that aim to disseminate and implement physical activity guidelines for persons with disabilities. For my postdoc, I wanted to dive deeper into KT science, specifically guideline implementation. With support from a KT Canada fellowship, I was grateful to work with Dr. Melissa Browers at McMaster University. I had the opportunity, like Megan mentioned, to contribute to the development of Cancer Care Ontario's Exercise for Persons with Cancer guidelines, and I established my own research program focused on physical activity guideline implementation, partially around these guidelines, but continuing to work with persons with disabilities as well. When I began my faculty position in the School of Kinesiology and Health Studies at Queen's, I continued this research program in physical activity guideline implementation. For example, I co-direct a community-based physical activity program for persons with disabilities and chronic disease in Kingston. This program is called RevDep, and it acts as a site of implementation of physical activity guidelines for these populations. In early 2018, one of the colleagues in my department, Dr. Robert Ross, was selected to chair the development of the Canadian 24-hour movement guidelines for adults and older adults. His awareness of my research program and background training in KT science led to the serendipitous moment when he asked me to lead the KT efforts for these guidelines. 24-hour movement guidelines are underpinned by the idea that movement exists on a continuum. Over the course of a 24-hour period, everyone engages in a mix of movement and non-movement behaviors, and these behaviors exist on a continuum from low to high energy expenditure. So starting with sleep, we know sleep is a regenerative non-movement behavior that expends very little energy, and we can find ourselves sleeping in a lying, reclining, or sitting posture. When we are awake and our bodies are in a lying, reclining, or sitting posture, and we are not moving a whole lot, we are engaging in sedentary behavior. So if you're sitting in a chair while watching this webinar right now, you're expending slightly more energy than if you were sleeping, and your non-movement would be classified as sedentary behavior. If you were to assume a standing position, or if you start moving more of your body while in a lying, reclining, or sitting posture, your energy expenditure would increase further, and then you would enter the green physical activity portion of this figure. As you move or engage more of your body, you expend more energy, and your physical activity intensity increases from light to moderate to vigorous intensity. Emerging evidence about the interrelatedness of these three behaviors has led to a paradigm shift in the literature, wherein physical activity behavior is no longer considered in isolation. I'll give you an example. I bet that all of us, perhaps even today, have found ourselves in a situation where we have not gotten a good night's rest. We may wake up in the morning feeling lethargic, and the fatigue can stay with us the whole day. Getting physical activity is challenging on the best of days, but on days when we have not gotten enough sleep, it is even more challenging to get that activity, and so we likely default to more sedentary behavior. However, time spent sedentary delays our sleep onset, which means another night of insufficient sleep, and so the cycle continues. Not only does time spent in one behavior impact our engagement of the other two, but all three behaviors have independent and combined effects on various health outcomes. The health impact of engaging in different combinations of these behaviors can be modeled with newer statistical techniques. Epidemiologists use isotemporal substitutions to model the health impact of taking time out of one behavior and adding it to another behavior. So, for example, what is the health impact of cutting our sleep short by 30 minutes and replacing that with 30 minutes of sedentary time, so like binge watching Netflix before bed, or 30 minutes of light physical activity, like going for a walk, or 30 minutes of moderate to vigorous intensity physical activity, like jogging. We can also look at the opposite isotemporal substitutions. What happens if 30 minutes of sedentary time is traded for 30 minutes of more sleep? What's the health impact of that? And so on. And so the take-home message of these isotemporal substitutions for all age groups is that for optimal health outcomes, we need to preserve our sleep, then maximize our time in moderate to vigorous physical activity, then light physical activity, and minimize sedentary behavior whenever possible. So if you would like and are able, you can stand during today's session because you would be replacing some of your sedentary time with light physical activity and thus be making progress towards a healthier movement profile. This paradigm shift in thinking about the integration of these behaviors has led to a reconsideration of how to promote physical activity at public and population health levels. Canada has been a leader in the production and release of physical activity guidelines for decades and is now leading the charge with the production of 24-hour movement guidelines that align with this paradigm shift. The Canadian Society for Exercise Physiology has led this charge with funding support from the Public Health Agency of Canada. The first 24-hour movement guidelines in the world were in Canada, and they were released for children and youth in 2016, and then for the early years in 2017. Each of these guidelines provide recommendations for how much physical activity, sedentary behavior, and sleep individuals should engage in over a 24-hour period for optimal health benefits. But for Canadians over the age of 18, the last physical activity guidelines are shown here. These were released nearly a decade ago, and sedentary behavior and sleep guidelines have not yet been produced. So given the substantial accumulation of evidence about these movement behaviors in the past decade, as well as the recent paradigm shift in their codependency, meant that it was time for us to embark on the development of 24-hour movement guidelines for adults over the age of 18. So I'm happy that these 24-hour movement guidelines are now in development, and they will be launched this coming October, at which point Canada will be the first in the world to have a complete family of 24-hour movement guidelines. So these movement guidelines are useful for a number of reasons. They can be helpful for setting behavioral benchmarks, developing public health messages, and establishing population-level surveillance. But their presence alone is not enough. There's a significant knowledge to practice gap in the Canadian setting. Despite the availability of these guidelines and the substantial efforts that have gone into branding and iconography and mass media campaigns, awareness and knowledge of the movement guidelines is low, with less than 13% of Canadians being aware of them. Behavioral targets also remain unmet, with less than 16% of Canadian adults meeting physical activity guideline recommendations. I represented this gap with Canadian guidelines and data. However, this gap is not unique to Canada. Despite extensive efforts to promote movement guidelines in other countries, similar gaps in guideline uptake have been noted worldwide. Those of us on the call know that knowledge translation, or KT, can bridge research to practice gaps. When applied to knowledge practice gaps for clinical practice guidelines in healthcare, principles of KT science can be effective for enhancing guideline awareness and use. But these principles have not yet been systematically applied to physical activity or movement guidelines in Canada. When I first became involved in the project, I used my background in KT science to try to pinpoint how to mitigate this gap. First, I considered that the majority of the work that had been done for previous guidelines in Canada was done in an end-of-grant KT manner. The guideline development team, made up largely of researchers working with a few partners, developed a plan for making the general public aware of the guidelines. An end-of-grant KT involves dissemination activities that aim to tailor the message and medium to the general public. So, for example, the iconography that was developed for the 24-hour movement guidelines represents the 4 speeds of movement behavior, so it looks like a 4, and it's intended to be a logo that would remind people to increase their amount of sweating and stepping, focus on a good night's sleep, and then decrease the amount of time they spend sitting. Another example of an end-of-KT grant activity is the Build Your Best Day online portal. Participaction, an organization that promotes physical activity across Canada, worked with the Children and Youth Guideline team to develop this portal as a way to engage children and their parents in planning for a healthy 24-hour movement profile in a day. While in theory this planning platform sounds like a good idea for dissemination, it was developed at the 11th hour right before the guidelines were launched, and unfortunately, guideline awareness and use of this platform continues to be low, as it does not seem to resonate with the target audience. So I thought, well, what if we used an integrated KT approach, whereby we engage relevant stakeholders and end users from the planning phases of the guideline KT efforts? KT science would suggest that this would help us close the knowledge to practice gap by making guideline promotion efforts more salient to the target audiences and hopefully more successful as well. An IKT approach would also make it possible for mutual learning to occur between researchers and stakeholders. Given the end-of-grant nature of previous KT efforts for physical activity and movement guidelines in Canada, it should not be surprising to us that all efforts focused on dissemination and the opportunity for implementation was missed. Just to ensure we're on the same page, I'll quickly define what I mean by these terms. Dissemination refers to the purposive distribution of the guidelines to specific audiences, whereby the end users passively receive tailored messages. Examples of dissemination efforts can include forced posts on social media platforms or receiving a copy of the guidelines in the mail or by email. When such strategies are used, at best, we can only really expect increased awareness and potentially knowledge of the guidelines. On the other hand, implementation refers to moving the guidelines into use by a target audience in a specific setting. End users have to take on a more active role in implementation strategies, but as a result, implementation strategies are more likely to change behavior in line with the guidelines. By planning both dissemination and implementation efforts using an IKT approach, I thought it would be more likely for us to see improved awareness and knowledge of the guidelines, as well as behavior in line with guideline recommendations. The third consideration that became clear early on was that I needed a process model or framework around which to structure and plan the KT work. The development of physical activity and movement guidelines are structured around a process that has adopted the agree to and grade evidence to decision tools. These tools are used for clinical practice guideline development more broadly, and this now, what is called the Movement Guideline Procedural Framework, has been adopted internationally as the gold standard for all physical activity and movement behavior guideline development. So I scoured the literature and I connected with national and international colleagues in KT of movement guidelines to see whether a similar type of framework had been developed, but for the KT side of the guidelines. And unfortunately, I came out of my search empty-handed. However, the colleagues I spoke with all agreed that establishing a KT process that other movement guideline groups could follow was definitely needed. So I was left with the task of establishing this process or framework. In recognizing these considerations for closing the knowledge to practice gap in Canada, I first sought out to establish the IKT approach for the work we were about to embark on. If we were going to engage in IKT, I needed to set up a team of relevant stakeholders to help me do it. But who were these stakeholders? I considered that the guidelines will serve Canadians who are 18 years and older, so I thought of people and organizations who represented adults at different stages of life, from university years to working years to retirement to older age. I also considered how adults and older adults may want to receive guideline recommendations. So I included stakeholders from organizations who may promote or be able to enact policy changes to ensure that the guidelines get promoted. The guidelines will provide recommendations for 3 behaviors. So I considered organizations and researchers who are experts in promoting these behaviors or have unique positions or skill sets that will help ensure Canadian adults and older adults are not only aware that these guidelines exist, but that they can practice optimal levels of these 3 behaviors. I consulted with researchers who had previously led the KT efforts for movement guidelines in Canada, as well as the Canadian Society for Exercise Physiology and the Public Health Agency of Canada, and we collectively made connections to build the best team possible. We decided to call this group the KT Subcommittee to distinguish ourselves from the Guideline Development Group. In thinking about who to include, I quickly realized that we needed a governance structure to ensure that we would effectively and efficiently accomplish our goals while working collaboratively. There was nothing published on how to do this best for our purposes, so I worked closely with the Public Health Agency of Canada and the Canadian Society for Exercise Physiology to establish a structure in terms of reference. We drew heavily on the terms of reference used in the Movement Guideline Development Framework. So expectations of the KT Subcommittee members include active participation in meetings, serving as a liaison to other sector organizations and stakeholders who would benefit from guideline promotion, providing timely and unbiased input into the discussions surrounding research efforts and evaluations, and then participating in the launch of the guidelines and maintaining confidentiality throughout the guideline KT process, so not going out and spilling the beans about what we were planning. Several members of the subcommittee also serve as part of a steering committee. Based on input from the subcommittee, the steering committee makes decisions to keep the KT process moving forward. The steering committee meets monthly to provide oversight, strategic direction, fiscal accountability, and attentiveness to the principles of implementation science. Now, during the formation of these terms of reference, the Public Health Agency of Canada expressed concern that many of the individuals who were on the steering committee were also part of the guideline development team, which could introduce a potential conflict of interest. Since they were providing our group with dedicated funds for KT activities, including evaluation, they wanted to ensure that the process would be as transparent and rigorous as possible. So we worked with them to come up with a solution to this potential conflict. Our collaborative solution was to engage a KT methodologist who is completely independent from the guideline development team. In consultation with the steering committee and the Public Health Agency of Canada, We identified a number of names of renowned Canadian KT scientists with expertise in Guideline KT. I reached out to the first individual identified, Dr. Melissa Browers, who accepted the invitation to serve as our methodologist. Dr. Browers and I then worked collaboratively to define the terms of reference for her role, which were approved by the Public Health Agency of Canada as mitigating their concerns about rigor and transparency throughout the KT process. So this KT methodologist is now a member of both the subcommittee and the steering committee, and she advises both groups to ensure the principles of knowledge translation are followed while serving as an arm's-length expert throughout the KT process. All subcommittee representatives were invited to participate in April of 2019. I sent them personalized invitations, and all 18 individuals responded with a very keen yes. As you can see here, our subcommittee has representation from a variety of academic, community, and government partners from across Canada, with individuals having varied positions, expertise, and career stages. Not listed here is that we also have a member of the general public to garner this additional perspective. The subcommittee, including the steering committee and methodologist, came together for a day-and-a-half meeting in Ottawa last June. The first objective for this meeting was to establish the criteria we would use to make decisions about the Guidelines KT activities moving forward. We wanted the group to have a guidepost when difficult decisions need to be made, as well as to ensure a productive and transparent KT process. To do this, the KT methodologist led a brainstorming session that offered IKT criteria from the literature that could be considered to inform our decision-making. Subcommittee members were then able to suggest additional criteria that they wanted the group to consider for decision-making. Following collaborative discussion, all subcommittee members were afforded the opportunity to vote on the top 3 items that they individually would consider being the highest priority. Vote frequency determined whether criteria were ranked as higher or lower priority. Following the presentation of rankings, the subcommittee collectively agreed that the criteria with the highest number of votes were of utmost significance, and though the lower priority criteria were still important to the group, they really wanted to ensure that the higher priority criteria be considered at the forefront at all of our decision-making. So the highest priority criterion was alignment with organizations' core values. In considering the values of all organizations represented on our subcommittee, the overall value was clear: a healthy Canadian population. This meant that at the forefront of all of our decision-making, we would need to consider that our KT activities were in the best interest of the health of Canadians. The second highest priority criterion was evidence of research effectiveness. The subcommittee believed that decisions needed to be evidence-informed. For example, is there evidence that a selected dissemination or implementation strategy will in fact be effective? And will we be able to properly evaluate our strategies to continue to advance the evidence base in this field? And the third highest priority criterion was feasibility. The group collectively recognized that our KT activities were operating within a fixed budget that had already been approved by the Public Health Agency of Canada. We also recognized that our team has a fixed capacity for how much we can accomplish, and that our KT activities must be complete within a fixed time frame, since the guideline launch date is set and the grant period has a hard end date. The following criteria did not rank in the overall top 3 priority. However, we still keep these in mind when we are making decisions and have found them useful. For example, sustainability of the strategies we are choosing is a key consideration. We want to ensure that our efforts are not lost after guideline launch and funding period ends, and that we have a solid footing to secure future funding as well as scale up of our activities beyond this grant period. And the criteria continue. So it's a long list, but our steering committee has found it helpful to refer to these criteria anytime we are faced with making a decision that has an influence on how our plans proceed, as well as in how we communicate our decisions to all members involved. With our decision-making criteria in place, we then collaborated on a hierarchy for decision-making. While group consensus would be ideal, it was acknowledged that the diversity of interests on the subcommittee may make consensus challenging. The final decision would ultimately need to be made by one individual who takes the group's input into account. We collaboratively discussed and decided on the following. Ideas for the KT plan are generated by the subcommittee. The steering committee discusses ideas and its idea alignment with the prioritized decision-making criteria. And while decision-making at the steering committee level is collaborative, the KT lead is ultimately responsible for making final decisions. It sounds scary, but I'm not left up to my own defenses. Our KT methodologist ensures that discussions and decisions uphold the decision-making criteria decided upon by the larger subcommittee. Dr. Browers keeps a watchful eye on the process and helps our group identify when we may want to pause and reflect, do further research, or consider alternatives. With our group structure and decision-making principles in place, we then had what we needed to begin planning our KT process. Turning to KT Science, I considered several planning and process frameworks that could help me structure the process moving forward. I landed on Graham and colleagues' Knowledge to Action framework for a number of reasons. First, the KTA framework could represent the processes for both guideline development and guideline KT, which would be occurring in tandem for the 24-hour movement guidelines. The knowledge creation funnel inside the green circle represents the work of the guideline development team, who are working on the systematic reviews and overviews of reviews to inform the guidelines themselves. The action cycle outside of the green circle would represent the work of the KT team, so the subcommittee, steering committee, and methodologist. Second, the action cycle of the KTA framework offers a series of dynamic steps that could help guide the KT process. Given our goal is optimal guideline dissemination and implementation, the action cycle offers some guidance about the type of formative research that is first required, identifying the problem, adapting the knowledge to the local context, and assessing barriers and facilitators to knowledge use. The action cycle also guides us with what to consider to evaluate our efforts, monitoring knowledge use, and evaluating outcomes. Third, and perhaps this is very Canadian of the group, but most of our group members had some familiarity with the KTA framework, and so its application to our process is easily communicated to all stakeholders involved. I took the liberty to slightly modify Graham and colleagues' representation of the KTA framework to operationalize the steps we undertook in the movement guideline KT process. I'll briefly walk you through each box or step to give you a sense of the activities that we have completed to date. I have already walked you through the knowledge to practice gap, or what I call here the guideline to practice gap, as well as the establishment of the KT team. So I'll continue with identify, review, and select focus of KT efforts. The second part of our KT subcommittee meeting in June 2019 was about focusing our KT efforts. First, the two steering committee researchers who led the dissemination of Canadian physical activity and movement guidelines in the past represented a summary of previous KT efforts. In addition, a representative from the United States' Department of Health and Human Services was invited to share the process that led to the Move Your Way campaign. This campaign accompanied the release of the U.S. Physical Activity Guidelines in 2018. The campaign was designed to raise awareness of the recommendations in the guidelines, as well as change behavior among the general public. The subcommittee was introduced to the target audiences, formative research, and findings with respect to key communication channels and messages, as well as the previous and future dissemination and implementation plans that were taking place in the United States. This information gave our subcommittee a frame of reference for how guideline KT processes may unfold and ideas for focusing our next efforts. One of the key takeaways was that the subcommittee recognized the need to offer guideline materials in two formats. The U.S.'s most recent scientific physical activity guideline document shown here is 118 pages long. It has long summaries of the scientific evidence followed by lengthy guideline recommendation statements, as you can see here. These scientific documents are intended for health professionals and policymakers, and they definitely don't motivate the general public, nor would the general public want to pick up and use this type of document. An additional set of public-facing materials, as shown on the right, presents guideline recommendations using inclusive imagery and specific messaging about the short-term health outcomes and disease management benefits of physical activity. The reason I'm telling you this is that in the past, Canada has traditionally only released scientific materials that provide the detailed recommendations without being overly motivating to the general public. So the subcommittee agreed that one of the main focuses of our efforts would be the creation of similar public-facing materials. Part of honing in on the focus of the KT efforts also included selecting target audiences for dissemination and implementation. In advance of the meeting, a survey was released to the subcommittee members describing what the guidelines would include and asked them to think about who should know the guidelines and why, and who should use the guidelines and why. My PhD student, Caitlin Koffeld, analyzed and presented the data at our meeting. Subcommittee members then engaged in small group discussions about target audiences, and the small groups reported back to a larger group discussion. The large group discussion elaborated on how the goals of KT efforts may be different depending on the target audience selected. For example, for some audiences, it is important to foster awareness and knowledge of the guidelines. For other audiences, though, it may be important to foster behavior in line with guideline recommendations. And if we want to facilitate behavior change, a third group of audiences who can enact policy change may be needed. We also discussed that there were three discrete age groups that were being reached with the guidelines, with each age group having unique characteristics and needs from each other. So young adults, middle-aged adults, and then older adults. Next, a round-robin activity was initiated. For each age group, a piece of flip chart paper was assigned for each of the three goals. Thus, 9 pieces of flip chart paper were created and posted around the meeting space. Subcommittee members then worked in pairs to write any individuals who could influence the achievement of the listed goal for the target audience. All pairs circulated around the room to add to all pieces of chart paper. Following completion of the activity, the responses from the flip chart papers were entered into an Excel spreadsheet and were organized by target audience, goal, and any potential influencers of the target audience. Suggested target audiences for each goal were ranked according to frequency. Activity findings were then discussed as a large group. It was clear that the target population for changing awareness of the guidelines should be all adults. Primary care providers and qualified exercise professionals like personal trainers or kinesiologists were identified as key influencers for this audience. The subcommittee also felt that it would be ideal to target all adults in order to change behavior. However, based on our higher priority decision-making criteria of feasibility, this focus was narrowed down via discussion to include young adults, specifically college and university students, and older adults, specifically individuals living in retirement residences. These groups were identified as they are captive audiences who spend a large proportion of each 24-hour day on campus or in their retirement residence, respectively. Further, several subcommittee members were well connected to target and reach these audiences and were willing to act as champions to facilitate the connections we needed to change behavior in these settings. Primary care providers and qualified exercise professionals were also considered key influencers of these audiences. Finally, in order to effect policy change so that the target audiences could change their behavior, the subcommittee thought it would be important to target policymakers on campus and in retirement residences. The subcommittee agreed that the steering committee could reflect and decide on these audiences using the established principles of decision-making. Over a series of meetings, the steering committee discussed the implementation target audiences at length. Due to funding, human capital, and time restraints, it was decided to focus in on one target audience to appropriately implement an intervention. There were several champions on the subcommittee who would be willing and able to facilitate an implementation intervention with university students. Specifically, myself and another researcher have trainee capacity to lead this intervention, as well as establish connections at our institutions to pilot the implementation intervention. Additionally, a subcommittee member is the chair of the Canadian Health Promoting Campuses Network, so he has the practical expertise needed to design an intervention for this audience and the network to facilitate intervention scale-up and sustainability across Canada following our pilot study. The outcomes of this step in our KT process were that we knew we wanted to produce public-facing materials for guideline dissemination and that we wanted to implement an intervention for university students to be able to enact the guidelines. This brought us to the next step in our formative work, which was to adapt the guideline to the local context, as well as to assess barriers to guideline dissemination and implementation. A series of formative research projects were designed. Because of the nuances in the target audiences selected, we parsed out this formative work into dissemination or implementation. To inform the development of our public-facing materials, 2 survey studies with large representative samples of the general public and stakeholders were conducted to elicit the ideal communication channels and types of messages that were desired and would facilitate individuals' self-efficacy to meet the guidelines. We then conducted a randomized controlled trial to parse out which message would in fact elicit the greatest self-efficacy to meet the guidelines, as well as guideline recall. These 3 studies were led by one of my master's students, Alexandra Walters, and one of my undergraduate students, Emma Fox. Collectively, these studies provided us with some take-home ideas that should be addressed in the public-facing guideline materials. First, end users need to see the public materials multiple times if we want to change their awareness and recall of the guidelines. These materials need to be disseminated through diverse communication channels, namely online sources, health professionals, and word of mouth. Second, the scientific recommendations in the guidelines are at too high of a literacy level for the general public, and so our public-facing materials must make the recommendations understandable and motivational. Third, members of the general public are overwhelmed by the idea of having to make changes to all 3 behaviors, and the targets are largely unattainable by most Canadians. Thus, our public-facing materials have to emphasize that any progress towards meeting the recommendation does come with some health benefits. And fourth, generic messages are more likely to enhance self-efficacy for meeting the guidelines. The most confidence-boosting message appears to be, move more, sit less, sleep better. And so it's likely that you'll see this message included in our guideline materials this October. At the same time that this formative work was taking place about dissemination, we started formative work to investigate the barriers and facilitators that university students face when they're trying to meet guideline recommendations on their campus. Because the target audiences selected for implementation were students themselves as well as campus stakeholders, we designed 2 sequential qualitative studies, one for each target audience, to get at the multiple levels at which barriers and facilitators to movement behavior change operate for students on campus. This formative work about implementation is being led by my master's student, Nicole Jarides, and data is currently being analyzed, so unfortunately I don't have results to share with you just yet. Once formative research findings are in place, the knowledge to action framework suggests that it is then time to select, tailor, and implement the strategies to disseminate and implement the guidelines. Recall that one of our high priority criteria for decision-making is evidence of effectiveness of the strategies that are selected. Unfortunately, though, there's a paucity of published literature about the effectiveness of previously used KT strategies for national-level movement guidelines. Given we wanted to ensure that any strategies we select are evidence-based, it was necessary for us to search for this information beyond published literature. So my team and I embarked on a systematic scoping review to try to pinpoint which dissemination and implementation strategies may have the most success. With the help of my 2 PhD students, Caitlin Caulfield and Tamara Morgan, we identified 47 eligible records from around the world, and I'll highlight some of our main findings. First, dissemination strategies are used much more frequently than implementation strategies. Only 16% of dissemination strategies were evaluated, and findings suggested that, at best, previously used strategies like distributing guideline materials and mass media campaigns lead to little or no change in guideline awareness, knowledge, or attitudes to using the guidelines. Implementation strategies were much more likely to be evaluated and associated with increases in self-efficacy, intention, and behavior to meet the guidelines. So overall, the review findings provide some insight into the types of dissemination and implementation strategies that we may select, that has clearly identified that there is room for improvement in publishing evaluations of KT strategies used in the movement behavior guideline field. With formative research findings and systematic scoping review findings in place, our next step will be to feed them forward to members of the KT subcommittee. We plan to engage the subcommittee in a series of webinars over the coming months to help us select and tailor the strategies we will use. For dissemination, in partnership with the Canadian Society for Exercise Physiology, Participaction has been contracted to develop the public-facing guideline materials, as well as the marketing strategy and public relations plan for guideline launch. For implementation, along with the subcommittee, my research team will engage in an intervention mapping process to develop an implementation intervention that is feasible and acceptable on the 2 campuses where we have done our formative work. As we plan our dissemination and implementation strategies, we will design an evaluation framework that allows us to monitor knowledge use and evaluate the outcomes of our strategies. Our ultimate goal is then to ensure that guideline dissemination and implementation continue beyond this grant period, leading us back to identifying whether or not our use of KT science helps us make progress in closing the guideline to practice gap in Canada. Overall, we have proposed a modified version of the KTA framework that we are hoping other movement guideline groups worldwide can look to for guidance when considering how they may do KT of their guidelines. Hopefully, as more groups use an IKT approach and a KT process framework, the science and promotion of health behavior guidelines will continue to advance, with more and more individuals reaping the benefits of engaging in healthy movement behaviors. So throughout this webinar, I've portrayed our IKT approach and the KT process as being straightforward, but this work has come with its challenges and many lessons learned. So I'm going to present some lessons learned today, and I'm hoping that they'll give you some insight about how the process we use may be applied and built upon by other groups, including some of the KT projects that you may be working on. The first lesson I quickly learned was that an IKT approach takes time, effort, and resources. Given the sheer number of people involved and their varying expertise and experience with guideline KT, it took more time than I expected to keep everyone on the same page. Constant communication between KT members is always crucial. Our first in-person subcommittee meeting was instrumental in establishing a sense of group cohesion and rapport to ensure that all subsequent email and virtual correspondence is not lost in the shuffle. Maintaining communication with those involved on the guideline development side of this work is also imperative. I'm incredibly grateful to our project coordinator, my former master's student, Stephanie Flood, who keeps both guideline development and KT processes on track. However, even with this constant communication, at times we have what I'll call functional disagreements about decisions that need to be made. However, these disagreements are productive in that they help us uncover where discrepancies in priorities or ideas are and allow us to listen, reflect, problem solve before we move forward. Because of the time and effort required, I was grateful that we started the KT process when guideline development began nearly 2 years ago. It was also beneficial to proactively plan for KT because I was able to add the many components of our KT process to the grant request from the Public Health Agency of Canada. The second big lesson learned is that IKT requires flexibility. As much as I had planned what I believed would happen in the KT process, I had to constantly adapt my thinking as guideline development and guideline KT unfolded. For example, the budget that I drafted for the KT process was done over 2 years ago, well in advance of our selection of the target audiences, and before we knew what we wanted to focus on for dissemination and implementation. Complete transparency in how funds would be used and managed continues to be critical, and thankfully the Public Health Agency of Canada has been incredibly understanding of our moving landscape. Another challenge I did not expect when I established the KT subcommittee was the high rate of turnover in staff in our partner organizations. This means high turnover in our KT subcommittee membership. Not only did these transitions mean bringing people up to speed, but it also meant trying to incorporate new priorities or ideas along the way to ensure that our newer members felt ownership and engagement in the process. And finally, perhaps the largest challenge that has required flexibility is the COVID-19 pandemic. The formative work done to inform dissemination and implementation was done in a pre-COVID-19 context. With physical distancing measures in place, the context has certainly changed. We know Canadians have increased sedentary time, alterations to their sleep schedules, and changes in time and space to get physically active. In addition, when it comes to disseminating the guidelines this fall, there will be greater noise in the health promotion space, with limited media attention afforded to the guidelines unless a COVID-19 angle is taken. Yet at the same time, our media relations plan will have to be creative so that we do not get swallowed up by connecting to COVID-19 only. Participactin is planning to monitor the media very closely, as well as design the marketing strategy as close as possible to guideline launch. In addition, we decided that our implementation intervention will target university students. We initially intended for the intervention to begin around guideline launch, but given the uncertainty as to when students will be back on campus and what campus will look like when that happens, there are obvious implications for intervention timing and strategies selected. And finally, I have learned that IKT fosters broader KT capacity. At the end of the KT subcommittee meeting last June, I asked members for their key takeaways. Almost all members said that they now have a better understanding of KT practice and science, which gave them greater confidence in their ability to engage in KT efforts within their own organization. For example, our stakeholder from the Canadian Sleep and Circadian Network said that she now understands how to engage relevant stakeholders in the development of her social media campaigns. Many members also noted that their involvement in the subcommittee has helped them expand their professional networks, which will help their own organization's work as well as their own organization's KT agendas moving forward. In addition, it has been amazing to see the professional development of my own trainees who have been engaged throughout this process. These students will be the next generation of researchers and practitioners involved in health behavior guidelines, and they already have the background and skills needed to research and practice KT in the health promotion space. This has definitely been one of the most challenging KT projects I have taken on, but it has been one of the most rewarding as well, and I am grateful for the opportunity. Once again, I'd like to acknowledge the Canadian Society for Exercise Physiology and the Public Health Agency of Canada for support. Ultimately, though, this work would not be possible without the many individuals who are part of the team. I would like to acknowledge our methodologist, steering committee and subcommittee members, our project coordinator, and all of my trainees who have worked tirelessly over the past year and a half. And of course, I cannot forget my team members at home who somehow managed to stay quiet throughout today's session. Thank you very much for listening, and I'm excited to hear your thoughts, reflections, or answer any questions you may have.
Thank you so much, Dr. Tomasone. That was great, and I made an effort to not sit the whole time. So we have a couple of questions coming in already. So let's take a look here. The first one is from Angela Fong. So she says, thank you for a detailed talk, Dr. Tomasone. Canadians are generally overwhelmed by the need to change 3 behaviors. What are your thoughts on focusing on promoting one behavior, like exercise, for example, over the 2 behaviors?
Thank you for the question. That is a good question. The challenge is that because we are producing guidelines that are promoting the codependency of the behavior, it is challenging for us to think about only promoting one behavior over the others because it ignores how they're all interrelated. However, if you look to the literature about multiple behavior change, it says that when you make changes in one behavior, it often leads to a trickle-over effect or confidence or skills to be able to change another behavior. So that's obviously something we're keeping in mind. The survey results from our dissemination studies say that Canadians actually want information about the behaviors that they find most challenging, that they're more likely to pick up the materials if we give them information about the behavior that is most challenging to change. And for most people in Canada, that is physical activity or exercise. And then also your consideration of thinking about exercise is that the isotemporal substitutions tell us that physical activity gives us the biggest bang for our buck when it comes to health outcomes. So we definitely are leaning down the road of thinking as physical activity as the gateway behavior, that if we can provide information about physical activity, usually as people increase their physical activity, they tend to decrease their sitting time, they start sleeping better, they start seeing the benefits, and so hopefully the cycle will continue. So that's definitely founded in the literature, and it's something that we will be considering as we design our public-facing materials. Thanks for the question.
Thank you. Okay, our next question is from Jasmine Ma, and she says, "Hi, Jen. Fantastic presentation. As always, I love the rigor in your methods. I'm wondering if you're able to share a little more information on which implementation strategies were found to be most effective in your scoping review."
Thanks for the question, Jasmine. Yeah, it was actually probably the most complex review that we have ever attempted to undertake because the idea of implementation of physical activity guidelines or movement guidelines, like what does implementation mean? Does it mean that the guideline had to be used in the intervention, or did it just mean that the intervention had to promote a behavior? So we landed on implementation meant that there was an obvious attempt for the participants in the study to be benchmarked against the guidelines. And so that sort of narrowed our scope a little bit. But what we did find is that for adults, the middle-aged adults, that financial incentives and workplace interventions to decrease sitting time and increase stepping and sweating time are helpful. So financial incentives is one option. We also looked at implementation toolkits. So there's a great example out of Wales, for example, where they bring all information about physical activity into one spot and have it tailored to all different health provider groups and policy maker groups. And there's a lot of planning tools and goal setting tools included in there. And so any sort of self-regulation strategies can be helpful to help people attain the guidelines. So I know your background is in physical activity behavior change, so some of these strategies probably aren't that surprising to you. And the reality is that they weren't that surprising to us from a KT angle either, because we know from clinical practice guideline implementation that providing options like education or training are not going to go that far to changing behavior. You need more active strategies where people have to do something to work towards their behavior change. But if you're interested in more, I can definitely share some more findings offline.
Thank you. Okay, our next question is from Christine Salib, and she said, "Thank you for your presentation. I'm just wondering if you have come across the most effective physical activity level we can do in the shortest amount of time."
That is a really good question, and it's something that I struggle with every day now, living at home in a pandemic and having very little time to get structured exercise blocks of time in my day. So interestingly, the physical activity guidelines from a decade ago suggested that in order to see health benefits, we needed to do physical activity in bouts of 10 minutes or more at a moderate to vigorous intensity. Over a decade of literature has added more information to us to tell us that we don't actually have to do it in bouts of 10 minutes, that any amount of moderate to vigorous activity actually accumulates to the overall amount that we're aiming to get by the end of the week, which is 150 minutes. So I definitely am hoping to take that spin in our public-facing materials, because in 2011, when the previous guidelines were released, it was said, you know, you only need 10 minutes out of your day. If you just take a 10-minute walk at your lunch break, that counts towards meeting the guidelines. Well, now it doesn't even have to be 10 minutes. It can be 2 minutes, or it can be 5 minutes, as long as you're getting your heart rate up. So I'm not sure if that answered your question, but hopefully it's a little motivational to everyone on the call that even just taking the stairs, for example, can make a big difference and get you closer to meeting the guidelines.
I think that's good news. The next question is from Lauren King, and she says, thank you, Dr. Tomasone, great presentation. I think you mentioned self-efficacy as an outcome for the implementation studies. What measures have you used or plan to use for self-efficacy, and how well does that translate to actual change in physical activity level? And how will you know your implementation efforts have been successful?
Thanks for the question, Lauren. So we actually haven't measured anything yet for implementation. We are still trying to figure out what our intervention is going to look like because we're targeting university students, and we're still waiting to find out whether university students sort of where they're going to be in the fall when the guidelines launch. Where we looked at self-efficacy was when we exposed individuals to different messages, so either lengthy messages or short generic messages about the guidelines, what was most confidence boosting with respect to wanting to do physical activity or decrease sedentary behavior or engage in sufficient sleep. And so we modeled our questions after advice from Bandura, but it was more focused around rank these taglines in the order around which they will help you elicit confidence. So you're absolutely right that if we measured self-efficacy in our implementation intervention, there's tons of confounders there, and that it's pretty distal from actual implementation of the behavior. So we'll have to do more thinking when we get around to designing our evaluation plan, but we're not going to do that until we know what our intervention is.
Okay, thank you. Our next question comes from Erin, and she says, thank you for your presentation. And she is wondering how you've considered equity within this process.
So that is a fabulous question. The Canadian Medical Association Journal actually published a commentary about this issue in January 2020 this year. And in our cross-sectional survey where we asked stakeholders for input about a draft version of the guidelines also pointed to the issue of equity, particularly Canadians who are of low socioeconomic status. And so we're committed to ensuring that our public-facing materials will go beyond just saying how much exercise a person needs to addressing why, how, and where different people can prefer and choose to be active. We're definitely also going to have to take a different spin now with the COVID-19 pandemic. So there will definitely be less focus on structured, organized activities outside of the home and more around easy solutions that anybody can do with just a little bit of space. And so the webinars that we're about to engage in with our subcommittee to design the public-facing materials, we've actually expanded our invitee list for these webinars beyond our subcommittee so that we have representatives from organizations that represent individuals who are of lower socioeconomic status or just a more diverse group, because we definitely don't want to perpetuate the idea that the guidelines are only for upper middle class Canadians. And so the biggest focus we'll have moving forward is that a key message is going to be that like anything that you can do gets you closer to meeting these, to obtaining health benefits. You don't have to meet all guideline recommendations in order to be healthy. And so far, our consultation with our diverse stakeholders have suggested that different equity groups in Canada would be interested in hearing that message.
Awesome, thank you. So we're just about 1 minute off of 1 o'clock here, according to my clock. So I think we can start wrapping it up. So thank you so much, Dr. Tomasone, for your presentation today. I know it's time is not in ample supply these days, so we really appreciate it. Thank you everyone for attending and taking time out of your day. I just want to remind everyone to please complete the online evaluation, or feel free to fill in the Word format evaluation that was in your email. I'll send the link to the online evaluation around again just after this. Our next presentation will be on June 11th. So usually we don't do the seminar series through June, July, and August, but this year we're going to have some in June and July. We have next couple are going to be in collaboration with the Sport Evidence Alliance. So we're going to have in June and then again in July 2 Sport Evidence Alliance seed grant recipients who are going to be presenting their work. So our next ones will be June 11th, and that's going to be Ms. Lisa Jones and Dr. Amanda Wirtz. So we hope you will join us for those. So once again, thank you so much, everyone. Please take care, and we hope you'll come back for our next webinar. Thank you.
Megan, are you still there?
I'm still here.
So do I just stop sharing and then you stop the recording? Is that how it works?
Yep, exactly. Yep, you can stop sharing if you like, and then I'll shut down the old WebEx, and we'll work on editing the recording to post next week.
Excellent, great. Thanks so much for coordinating, Megan, and for getting all of those questions through. I appreciate it.
You're very welcome. Thank you so much. Enjoy the rest of your day.
Thanks so much. You too.
Take care.
Bye.